Oh, nak connect tu. Connect dengan diorang. Jangan cakap lagi lah.
I think this Da Vinci yang pandai. Benda ni dia buat untuk urology also.
So these are all ada mati.
I think the Da Vinci show dia akan develop so multi-specialty. Dia mesti fikir about market dia. Oh ni single arm ya.
Single arm.
I mean single
Single port access.
So that means they clear already for urology usage.
I think they thought about it, like what you said lah, for multi.
That's yeah. This one dia boleh macam lengthen sort of.
You can go, yes.
In out.
According to the depth lah. And the camera ni, it's like an endoscopic camera. Endoscope, dia macam bronchoscope punya kamera lah.
Oh yeah.
So
dia boleh view angle. Tapi kalau this one dia orang buat, how about stapler?
Stapler melalui the same port.
Guna different. No, I mean bukan using the robot stapler. No, normal stapler.
Normal stapler. No. There's a design. So, but it could goes with the same port. Bukan arm.
Not the arm.
Hi, morning, bro.
Morning. Oh, why? Last time tak ada backdrop. Oh, that's the YouTube link.
YouTube link tu. How to send the link?
Kenapa gambar ni jadi macam kecil?
Tadi, no. Adjust the camera, they can give me zoom.
Tadi dia nampak semua.
No. You cannot cross that out, right? Because the whole zoom.
Yeah, the whole zoom. How do I minimize this chat?
Oh, you just let me see. Ada tu. That's it.
Kamera tadi dia nampak 3-3. Why now dia jadi macam only on me?
Dia bila cakap nanti dia akan zoom ke orang tu.
Oh, automatic. Oh, canggih lah ini kamera.
I got testing.
I'm not sure how many will turn out, but I distributed to that's as much as we can. Dia ada tu diorang tengah set up dia punya yeah. Last time berapa hari? Dia must be diorang punya Zoom lah. Because I think dia punya ada speaker maybe pun tak ada kat situ kot. Sebab dia tak duduk sebelah. Tengok. Dia pun tengah share dia punya screen. Oh, Siva was telling me there's the Da Vinci ada that single arm punya robot. Huh? You said dekat Shanghai, China, they started using it for
thoracic already.
But they using it for urology as well, right? That thing, that single. Single arm for prostate lah. Multiple lah. Because potentially that should be more economical lah for single arm. I don't know lah. You don't think so? They'll try to make money somewhere.
Yeah, I'm very good to recycle.
They are very clever, preventing recycling. Every single thing they put some chip or something too. Dia tengah tu.
Tapi kita punya sudah
Siapa yang tengah jalan?
Speaker 在这里，都收得很好。Good morning. Can we start?
我们的麦克风呢？直接这样子是吗？不要把它过来，但拿靠近一点嘛。先把麦克风拿靠近一点。直接放来。
这个收得很清楚。
放过来一点。可以的吗？他声音听得到吗？那是我开始吗 ？Hello, good morning. Hello, Professor Sarah.
Good morning.
Can you hear me?
Yes, crystal clear.
Oh, selamat pagi.
Selamat pagi.
Okay, I think we just start now. So a very good morning to all participants who joined this webinar. I'm Dr. Lau Hui-Ping, Professor and Senior Consultant Surgeon of Thoracic Surgery in Chang'an Memorial Hospital. It is my pleasure to welcome all the participants this morning, and we are especially grateful to Cardiac Thoracic team led by Professor Sarah Hashim, and the two honorable speakers, Dr. Siva Kumar and Dr. Ali Azam. And also I appreciate the speaker from Chang'an Memorial Hospital, the thoracic surgical team, Dr. Wu Qingfeng besides me, and also Dr. Chen Wei-Xin, and all the other colleagues present here who makes this web seminar happens. And this conference is being conducted along with the collaboration in medical education, the scholarly communication and clinical training program between and Chang'an Medical Foundations. And also this is the first conference between and CGMH Thoracic Surgical Team to face or sit together to share our experiences in minimally invasive lung cancer surgery. And also the first time which is conducted on a digital platform in line with the social distancing norms due to the COVID-19 pandemic. Welcome and thank you for your participation. And I would like to pass the mic to Professor Sarah Hashim. Hello.
Hello. Thank you very much, Prof. Lau, for the introduction. We are very honored to have this digital session today. As you said, this is the first time that we have a thoracic surgery webinar between Chang'an Memorial Hospital and University Malaya Medical Center. I think I would like to start the session first without further delay. First, if you don't mind, I would like to introduce Professor Siva, who is sitting on my right. He will be giving a talk on the evolution of VATS surgery. Professor Siva is a graduate of University Malaya, and he went on for training in cardiothoracic surgery here in University Malaya and also in IJN, the National Heart Institute. After that, he went to United Kingdom to further his training in cardiothoracic surgery. And recently, he also went to Shanghai to subspecialize in uniportal surgery training under the guidance of the world-renowned Dr. Diego Gonzalez. So without further ado, I think Dr. Siva would like to share his experience in VATS surgery. Basically, we want him to look into the evolution of VATS surgery. Thank you, Dr. Siva.
Thank you very much, Prof. Sharul. I'll just share my screen. Okay, can you all see my screen?
Yes.
Okay, thank you. All right, thank you to Prof. Sharul for the kind introduction. I will start off first with the multiport, uniport, and microportal VATS lobectomy advantages and disadvantages. Now, a quick overview. I will just talk about a brief introduction about VATS surgery, what's multiport, what's uniport, microport, and summarizing all of it. So basically, what we have to understand that surgery is not a static entity. Now, VATS surgery has been there since the early 90s. To basically, in thoracic surgery, what's different compared to the rest is how we enter the chest. And when we enter the chest, all we need is a pair of eyes, pair of hands. But what makes thoracic surgery different than other general surgery components is the intercostal space. And we basically got to spread the ribs to enter. So the initiation of VATS came with that, where the idea of not spreading the ribs came about. And the initial definition for VATS came out with Shigemura, where he said the complete VATS approach is a non-rib spreading entity via total endoscopy. So what's multiportal VATS? Now, multiportal VATS is basically the conventional VATS that has been used over the years. There are two approaches, anterior or posterior approach. And the proper definition of multiportal VATS lobectomy came from the CALGB 39802 trial, which basically defined it as at least a maximum of 8 centimeter combined incision with isolation of each pulmonary artery, vein, and the airway. At the same time, a total endoscopic view without rib spreading. Now, when we talk about a particular procedure, the division of it based very much on its evidence. And what are the evidence we have for multiportal VATS? And that evidence can be divided into the birth of the procedure, the infant level of the procedure, the childhood, adolescent, and adulthood, where it becomes an established practice and technique. Now, this is a simple overview about how the pots are placed in multiportal VATS. Basically, the idea is to get the axis from the umbilicus facing towards the shoulder. So it's a diamond shape. It can be 3 pots, it can be 4 pots, depending on where you want to place the additional pot. But mainly the utility pot will be in the anterior, if you're going on an anterior approach, and a posterior if it's a posterior approach. Now, what's the advantage with multiportal VATS? Now, there are a lot of evidence that has emerged over the years, which has actually reached until adulthood for multiportal VATS, where enough papers have said that it causes less postoperative pain, shorter length of stay, lesser morbidity, earlier shoulder movement, better quality of life, and early mobilization. I mean, this can be seen by the papers came out by LNCO in 2011. Even Shigimura did a prospective RCT comparing both these techniques, and that was published earlier part in 2004. And the latest Violet trial, which Eric Lim just announced the results in ISLT last year, 2019, which basically says that VATS surgery is not inferior to open thoracotomy in terms of survival, shorter hospital stay, lesser morbidity, and better quality of life. There were some who also looked into other aspects of VATS, where they went into the molecular aspect, and it was also proven in some papers that it had lesser inflammatory cytokines, humoral and cellular immune activation. And this was published in Annals of Thoracic Surgery in 2001, and also Craig SR published it at the same time in European Journal. Now, what is important that we need to know here, whenever we change a traditional technique to something new or an evolving technology, it should not compromise oncological principles. And this is further supported by Watanabe, Sagawa, and Delniger, with all the papers saying that VATS in any form has no compromise in oncological principles, and the same yield of lymph nodes were harvested for staging using VATS. And what's appeared lately in the latest journal in Respiratory 2020, LNCO published that in very high volume centers using VATS, whether it's in multiportal or uniportal, it's a very low mortality rate, which is less than 0.1%. Now, this is a bit different than the UK data, which quantifies all forms of lobectomy to have a mortality rate of less than 1%, but that they're only talking about open lobectomy. Now, what does multiportal VATS have to offer for institution? Now, for institution, it causes basically cheaper costs because of a shorter hospital stay, so low investment, and they get a higher return, and precise usage of staplers, because when you isolate your vessels and when you skeletonize them, you limit your amount of staplers that you got to use rather than taking it as an end mask or even dividing the fissures in a more precise manner. So that means cheaper cost for the whole operation. For the surgeon, what is it used? It gives better visualization for surgeon. You don't have to dive into a very deep cavity in the thorax. Precise dissection, so vascular and parenchyma can be dissected precisely. And for some who are very experienced, you get a better vascular control. Equal or shorter operating time, and this is very much with experience. And of course, in good hands, a lobectomy can be as short as less than 60 minutes. What are the disadvantages of multiportal VATS? Now, there have been some evidence that say some patients do experience of chronic pain because of multiple compression over different intercostal spaces of the intercostal nerve, multiple small scars. In difficult situation, if patient develops injury to major blood vessels or catastrophic situations, that can be a challenge to handle, especially in surgeons in the earlier phase of VATS evolution. And there have been reports stating of pot site metastases, especially if the tumor is removed without using an endobag or an endocatch, and it comes in contact with the bone or the muscle when the tumor is removed. For institution, what is not good for the institution is during the earlier days of the surgeon's training, where they take longer operation time, and that means higher costs. And for surgeons, there's always a learning curve. And one of the issues that has always been highlighted in a lot of journals is the issues with surgical ergonomics. Mainly, some would complain mechanical back pain or neck pain as the arms got to be outstretched in two opposite direction to maneuver for the instrumentation. Now, coming from multiportal VATS, now we zoom down to Uniport. Now, what is Uniport? Uniport is basically all instruments that goes through one single incision. There is an evolution from 3-port to 2-port and then to 1-port. Some surgeons evolve from this, some straight move on to Uniport, and I'll tell you why. Now, the change of view from umbilicus to shoulder, as I showed earlier with multiport, has now become nipple to scapula with Uniport. That means your view is more towards the scapula from the nipple side. Now, the good part about Uniport is you use your same instrument sets. Only thing, some instruments are a bit more angle in certain preferred situations. Now, this is basically the view for Uniport. So as I showed earlier with multiport, it's from umbilicus to shoulder, but with Uniport, it's from nipple to scapula. So all your view is in this direction. And what is good about this is it's exactly the view you do when you do open thoracotomy. So either an anterior thoracotomy or posterior thoracotomy, the view would be the same in this situation. Now, the basic principle under Uniport is the traffic light principle, and I think this is what all who are embarking into Uniport surgery should understand. Red means don't move, so your camera is right on top, red light, so it will always stay static, and that's why your assistant will hold it. Yellow, you can move a little bit here and there, but you got to slow down, and that's why your graspers are placed to retract and to expose your view. And green is all your movable instruments, could be your harmonic scalpel, dissectors, and even your stapler. So the traffic light principle is what we use and we embark into the principles of Uniport VATS. And this is basically the evolution of Uniport VATS from where it started in, basically they started off in 2005, but complex resection only started on from 2013, where the complex lobectomies were revolutionized by Dr. Diego Gonzalez Rivas, and that followed on with sleeve in 2013, PA reconstruction in 2013. Then they moved on to non-intubated, and of course, they started off with hybrid OR imaging, and now with laser pulmonary resection, which is something revolutionized in 2017 for metastatectomy, where also they use it through Uniport XS. And the natural orifice ones, where they have now evolved right up to subxiphoid for lobectomy, and of course, transcervical wedge resection in 2014, and transcervical lobectomy in 2016 in certain centers in the East. Now, what are the advantages of Uniport VATS? The advantages basically is exactly the same as multiport. It's feasible and safe. But this was well documented by Diego in 2011 in ICVTS, and recently further echoed by LNCO in JTD in 2016. It causes lesser pain. Lesser tissue trauma is what a lot of the uniportal VATS surgeon highlights, because the muscles are not divided, but they're only separated and only through one incision. So lesser tissue trauma means lesser release of cytokines, inflammatory components, and of course, lesser SIRS after surgery. Of course, the patients still share the similar discharge time. Some reports have documented early recovery to daily activities. The birth of ERAS program is very well supported with Uniport because they will go on digital drain, single drain with a single port, lesser opioid usage. And in fact, in my practice, I don't use opioids. We just use NSAIDs as your post-op analgesia. And this has been basically highlighted by Hirai in the recent publication in EJCTS and Zhu in the Translational Medicine 2015 on the safety and efficacy of Uniport VATS. Now, for institution, what do they benefit from Uniport VATS? The birth of the ERAS program, a well-structured pre, intra-op, and post-op program in thoracic surgery. We have got ERAS in general surgery, and now in thoracic surgery, it's the next boom, and followed on by certain centers applying it as part of their routine practice. No additional investment in instruments. So basically, what you have invested for multiport, you can always use it for Uniport. And of course, it attracts more patients, and it becomes a one-stop lung cancer center. In certain centers in China, they incorporate it as part of the practice where diagnosis is made, and then the pathologists read the slides, and within the same time, after the diagnosis is made through navigational bronchoscope, they move on to Uniport VATS, either a segmentectomy or even a lobectomy. For a surgeon, what is the advantage? There's a shorter learning curve because the anatomy is very much similar as open, a platform to evolve to other more complex uniportal surgery like subxiphoid, and of course, uniportal robotic VATS, which is another new emerging technology that is out. And in certain centers where you do not have many surgeons to assist you, you can adopt this concept of unisurgeon, uniportal, a single surgeon practice where you can even anchor your camera port with a stay suture and the rest of the instruments to move around according to what you need it with your two hands. So you do not need many people, and that also can cut costs. And of course, there's always training availability in high volume centers. And that's basically what I adopted during my experience in Shanghai, where they use the learning module evidence-based. Now, there was a systematic review and meta-analysis of Uniport versus Multiport, which was published in Annals of Thoracic Surgery. They basically looked at 8 observational studies, and they found that Uniport has lesser complication rates, shorter length of stay, shorter chest tube duration, no significant difference in mortality, operation time, perioperative blood loss, and also the rate of conversion is exactly the same. Now, the motivation for me to get on is when I had my chance to attach in Shanghai with Diego, and this is one of his books which he wrote. It's available in most of the online platforms. And the module that they used was published in ICVTS in 2017, where it's a high volume intensive training course, which used for Uniport VATS. Now, what they advocated is basically break down your steps into small steps. So you start on with camera positioning, assistant positioning, lung retraction, major structure dissection, staple application technique, segmental anatomy, specimen removal. And there's a lot of online videos available on YouTube and some of the online platforms, so that can be accessed for anyone who's wanting to embark into uniportal surgery. Now, uniportal surgery, what are the disadvantages? We find in some patients, because you enter through the same side, the utility port for the chest tube, chest wound SSI has been an issue. In the early days, again, long operation time is a problem for some surgeons. And for the surgeons, they are basically operating in a non-favorable anatomy because it's a small confined space. Ergonomics is more of a problem for the assistant rather than surgeon, because the assistant had to stand across holding the camera and retracting, so they may experience back or neck pain. And sometimes in the more junior situations when we are dealing with life-threatening complications, it can be difficult to address. And in terms of the hierarchy of doing a lobe, the first lobe, what was recommended to start is a right upper lobe, followed then by a left lower, and then right lower, and then right middle, and finally left upper. But always there's been difficulty whenever you encounter lower lobes, because the two, where you need to probably consider the two-port technique, because it's much superior in terms of retracting the lower lobe. And sometimes with Uniport, there might be difficulty encountered to deliver larger specimens out. Now, based on evidence, what we got for Uniport currently at this level, it's still at a childhood level. So you can safely say it can be performed, but we still can't come out with a statement that it should be performed. So it's a technology that is being evolving, and probably, as you can see here, the Uniport Robotic VATS is out. Trials done in many centers, and Shanghai Pulmonary has embarked into getting involved in as one of the trial centers. And we never know what will come with this. And the last part of my talk will be on microport VATS. Microport VATS, it's not much difference than multiport. It's just all similar as multiport, but with smaller incisions, 3 to 5 millimeters. The advantages, it's very much identical to multiport. However, it's got a very low adaptation rate. And the reason for that, it's mainly because of difficulty in delivering specimens out. The disadvantages of multiport is microport is exactly as multiport. It's suitable in only certain procedures, and when it comes to difficult complex resection, multiport might be better, or even uniport. So in summary, when we want to embark into a new surgery or technique, we need to understand the theory and science behind it. We need to attend meetings and live surgery sessions. We need to be directly involved as an assistant first. We need to perform and progress in the taxonomy of skill development. We need to audit our own series then, and to continue improving to refine techniques. So we would prefer to be early adopters in the first 13.5% of this Rogers adaptation innovation curve, rather than the late majority at the last 16%, where the technology after 15, 20 years then only adapted. So with that, I would like to thank you. Thank you. Oh, sorry.
Thank you. Thank you, Prof. Siva, with that very good talk, very like eye-opening talk about the different type of multi-port Uniport and Microport VATS lobectomy. Without further delay, because we're running a bit late, I would like to introduce our next speaker, who is Dr. Adli Azam. He is from University Technology Mara, but he also used to be a surgeon here in Dr. Adli currently is the head of cardiovascular and thoracic surgery department in UITM. He trained in UKM and then undergo his cardiac surgery training in University Malaya and also in IJN. And following that, he went to Seoul National Hospital, Bundang, to train in minimally invasive thoracic surgery, where he had the opportunity to train under Prof. Park in St. Mary's Hospital, Seoul as well, for pectus surgery. So and also Dr. Adli, I think, is the only surgeon in Malaysia who has embarked in robotic surgery in thoracic surgery. So I would like him to share his experience in robotic lung cancer surgery in his institution in particular and also in Malaysia. Thank you. Dr. Adli.
Thank you, Sharon. Thanks for your kind introduction. I just go through within these 10 minutes about lung cancer robotic surgery. I think robotic surgery is actually a transformation from minimal surgery evolution. Use of a robotic arm and tools during surgery. Human interaction still necessary, of course. It can control by voice, remote, and joystick. It allows accuracy and precision which is unmatched with surgeon's hand. When we talk about advantages, actually it's the same as other minimal invasive surgeries. We are talking about minimal invasive, small incision, less bleeding, less pain, faster recovery, short hospital stay, and also less cosmetic distortion. And if we compare robotic versus a non-robotic minimal invasive surgery, we are talking about 3D vision, more high definition visualization, a better dexterity compared to long instrument, and less fulcrum effect. The technology that the robotic always talk about is actually Endoris technology, which actually you are working as the wrist inside your surgical cavity. And of course, a shorter learning curve compared to laparoscopic surgery for a surgeon who already comfortable with conventional thoracotomy. Advantages for surgeon, of course, is less fatigue because sitting down, faster than conventional in terms of the surgical procedure, not of setting up, decreased margin of error because we can program to compensate for tremor. There's a few ideas saying that robotic actually cost efficiency because when they talk about fewer people in operating room, because robot going to take the role, and it's less invasive, of course, because with the advanced surgeon become farther from the patient. Again, when we talk about lung cancer surgery, pulmonary lobectomy has been standard care for patients with early stage lung cancer. Development of VATS technique and ability to perform lobectomy with small incision has significantly improved in terms of perioperative mobility, post-operative and length of stay compared to open thoracotomy. And we talk about minimal invasive lobectomy. I think Mr. Siva already explained in length about the minimal invasive lobectomy and procedure of multiport VATS thoracic surgery. And VATS lobectomy for lung cancer provides good preoperative outcome without any hindrance in 5-year survival and also overall survival. Why robotic surgery for lung cancer? I go through a few papers that this is among, if you see the papers in the about robotic surgery in thoracic surgery, this is among the last, I would say, less than 10 years, a systemic review and meta-analysis on pulmonary resection by robotic video-assisted thoracic surgery, looking at 9 studies from 12 institutions, and most patients actually are early stage non-NSCLC. In conclusion, robotic VATS is feasible and can be performed safely for selected patients and specialized centers. Perioperative outcome and post-op complication similar to VATS. Another paper by Cance, looking and review of the national database, say that outcome of robotic platform has shown similarly improved perioperative mobility, less postoperative pain, and shorter length of stay as VATS platform. This is another paper looking at the STS database, compared the VATS and robotic approach for clinical stage 1 and 2, which is early stage lung cancer. Looking at the high volume center in 4 years' time, in stage 1 and 2, and they're compared of 1,200 robotic lobectomy versus 12,000 VATS. And the quality metric evaluated was operative morbidity, 30 days mortality, and nodal upstaging. It's interesting to see that the data show robotic lobectomy have more comorbidities to the patient, from the patient, and they have a longer operative time, which is anticipated, because I think this is at the part of learning curve of doing a robotic platform. But complication, 30-day mortality, hospital stay, and nodal upstaging is equivalent between both techniques. So Falio write an article because he's one of the renowned thoracic robotic surgeon in the world about robotic lung resection for non-small lung cancer. He's talking about robotic assisted pulmonary lobectomy can be considered for patient able to go for conventional thoracotomy. Team training, equipment familiarity, troubleshooting, and preparation are critical looking at the successful robotic lobectomy. Associated with decreased rate of blood loss, blood transfusion, A-leak, chest tube removal, duration, length of stay, mortality compared with thoracotomy. And robotic lobectomy offers many of same benefit in pre-operative morbidity and mortality. In addition, advantage in optic dexterity and surgeon ergonomic as VATS lobectomy. Of course, at this point, long-term oncology efficiency, efficacy, and cost implication remains area of study. This is another paper which looking at the long-term survival based on the surgical approach to lobectomy for early stage non-small cell lung cancer. Is compare of robotic VATS and thoracotomy lobectomy. A single center, 10 years duration, 470 patients with 3 cohorts, and is to assess overall survival. This is among early paper looking at the overall survival using robotic platform and also disease-free survival. In conclusion, it's a similar long-term overall survival in all techniques. Use of minimal invasive surgery, either VATS or robot, is associated with shorter length of stay, and robotic approach resulted in greater lymph node assessment. In discussion, they mentioned that this achieved because of good visualization to do a lymph node dissection. Other paper looking at this is another paper by Soffolio looking at the 5-year survival in non-small cell lung cancer. It's a retrospective review, almost more than 1,000 patients for 13 years. It has excellent stage specific in 5-year survival rates. Median follow-up of 30 months with overall metastatic recurrence rates of 15%, local recurrence rates of 3%. And his impression was due to improved lymph node dissection, it allows better staging and patient have a benefit to receive adjuvant chemotherapy. Of course, he said in the discussion that you have to consider surgeon factor. This is latest paper talking about robotic assisted lobectomy for a non-small cell lung cancer, a comprehensive industrial experience. It's a prospective surgical database looking at the 6 years duration in 800 patients and compare between robotic lobectomy, VATS, and open lobectomy. They conclude that robotic lobectomy was associated with improved nodal harvest and less blood loss compared with open thoracotomy. Length of stay is shorter with a robotic platform as opposed as open lobectomy. Unexpectedly, cost was not higher. I think it's because of the setup and the management which lead to this conclusion. Otherwise, patient profile will receive robotic lobectomy may allow thoracotomy patient to receive minimal invasive surgery after adequate training and experience. So what do we learn from this available data? We understand that robotic surgery is minimal invasive surgery. Perioperative outcome and post-op complication is similar to VATS. Perioperative mobility, less post-operative pain, and shorter length of stay. No significant difference in early lung cancer, especially stage 1 in survival compared to both other technique. When we talk about robotic lobectomy, there are lots of discussion talking about improved lymph node dissection because it's allow better pathology staging, so patient can accurately stage for the lymph nodes and receive adjuvant chemotherapy as such. Yet, of course, we have to consider surgeon factor. In UITM, we have our robotic surgery unit, not just in thoracic, it also involve cardiac, gynae, and of course, to be successful robotic surgery program, you need a proper, highly specialized and trained team. It involves surgeon, anesthesiologists, and operating room staff nurse. And of course, we have to maintain the safety and efficacy, which have adequate referral base. I will say I am still neonate in thoracic robotic surgery. I only performed only 5, only 1 lobectomy. The others was just a tumor, posterior medial mass resection. In setting up a robotic surgery program, of course, it's of challenges. We have to select our patient. The cost is always a problem. We have to discuss in terms of cost, limited training opportunity, and where we have better option. If you ask me if I want to do thymectomy, I can do with VATS, maybe faster, because the instrument, we have better instrument right now, and we can see that there is evolving endoscopic instrumentation. I think most of us work in thoracic surgery. We can see the evolution in endoscopic instrumentation, and we can see the heterogeneous clinical outcome. And VATS actually is cheaper in terms of setting up the instrument and so on. Why I'm doing this, because it's the future. We have nanorobot, which already on board in research. They're working hard on it. And this is on 8 years ago. Snake boats is one of them. And just now, Siva mentioned about this, Da Vinci SP. Virtual reality is not something which is very rare. People talk about it, all the research working on it. Augmented reality is the real. It's not only in drama, movie, but it's already in research platform and going and to the application. Microsearch is one of them, but this is really our future. Thank you.
Thank you, Dr. Adli. That was very interesting talk on and very enlightening on robotic lung cancer surgery. I would like to pass the mic to Prof. Lau for his surgeons to talk about their sessions today. Thank you.
Thank you, Professor Sarah, and the 2 honorable speakers from the very good talk. And because of the time, I would like to move to the next topic, taught by Dr. Um&Cgmh, the feasibility of single surgeon and single port surgery. Dr. Wu actually is graduated from Kaohsiung Medical University in 2009 and is now the assistant professor in Department of Thoracic Surgery. Also, he's the clinical fellowship training in La Corona Hospital in Spain and from Dr. Diego. And also, he have experience when going to Shanghai Pulmonary Hospital to learn the Uniport. Dr. Wu, please.
Thanks for the introduction of my dear Professor Dr. Liu. And today I want to share my experience in uni surgery in single port surgery. But you know, I want to give a more easy talk because it's like communicate with what we could get from our experience. For a single port surgery, it looks like a tree just in the snow, lonely but to be strong. If you keep in mind to go on this technique, you will find everything could be stopped in one single incision. You know, the Iron Man is like a human machine, and we know to combine the advantage of robotic and human intelligence will be very amazing in the future. You could see the video like on your right. This is another example to integrate the machine and the human resource. The man is in the United Kingdom and want to search for a patient in the hill. So now they develop a new machine like a rocket man. You could see with this technique, he could fly and he could search the patient very easily. So to combine the robotic advantage and the human intelligence is very important in our future. And the next step may be like this. you could see many fiction movie, and you will see how the robotic to repair the robotic. In this situation, we will know no human being will be in the operation room. So maybe you could image when you're lying down on the table, around you our robotic surgeon is very amazing or very astonishing. But in reality, what the robotic today is look like this. You could see a lot of people do around the machine, and then you could see the patient still could see the doctor. But in the year of COVID-19, you could image this like very easy to contaminate it with if the patient has high possibility of COVID-19. So from the world report, from the WHO report, we could see the in the year of COVID-19, the population of infected with COVID-19 is increasing. Even though we now have vaccine, but we still didn't know whether we will close the pandemic year. So according to the suggestion of NHS, they told us we should keep with personal distance about 2 meters. But according to the Taiwan's sanitary department suggestion, we should keep for 1.5 meters in the house. So how we imagine in this operation room, we're still very close to the others. So even for a surgeon, we should not stand out of it. According to the suggestion of American Association of Thoracic Surgeons, you could see they divided for 3 phases. For the phase 1, very few COVID-19 patients in your hospital, you could do everything as usual. But when we advance into the phase 2, you could find the surgery we have to do is lesser than previous, even especially for the perforated cancer of esophagus or the infection related to the tumor, or about the tumor associated with hemorrhage, or the patient cannot amenable to non-surgical treatment. So when we advance to the phase 3, the resource of personal protective equipment is very precious. So when we could divide it for the patient with perforated cancer of esophagus, septic patients, threatened airway, or tumor-associated sepsis patient will enroll to the surgery operation room. According to another suggestion in the operation room, is published in British Journal of Surgery. It's data gathered from all the Western countries without mainland China and Taiwan. It's very interesting because we know the pandemic is increasing in the Western country. They divided your patient into 2 groups. Or blue man is like the patient without any symptom or is PCR negative in COVID-19. At this time, we could wear our mask and the gloves. As usual, we do the same operation in our operation room. But when the patient was like a red man, he might have a symptom of COVID-19 or his diagnosis of patient of COVID-19. You have to wear your protective personal equipment. So when the resource was limited, you have to choose. As the Professor Siva, who talked about previous, single pole surgery is like a history. Can we be better? We could with the evolution of the surgical technique, we reduce our surgical wound and his size. But how about the participation man? My professor, Dr. Diego, who published his first experience in unisurgeon in single pole surgery. At this time, I want to show this my dear professor, Dr. Liu, who performed the traditional VATS surgery. His picture is very young. And with the time going by, the participation assistance, the number of participation assistants is decreasing. Because see, when in single pole surgery, they just need two surgeons. And now you could see when I do the surgery, I only use the robotic arm to assist me, and I could do the same thing as usual. So in our hospital, we have two systems of robotic arm machine. The first one, I do not suggest in daily routine, but the second one like this is like the arm or wrist of the human being. So it could reduce the body space for you to introduce your instrument more smoothly. So what you see is very lonely, but in the operation room, you could see it's very. We could keep personal distance about 2 meters, so it's very safe, even though the patient is highly possibility of COVID-19 patient. But fortunately, in Taiwan, we didn't go into phase 2. We only stay in phase 1. So regular protective maneuver is enough. So you could see the next video, you could see the image in the thoracic cavity. It's very stable without tremor. Even though you put it in the instrument, it's very easy. So the patient was a patient who has tumor in vascular pericardium. You could see with the stable image, we could do everything, like a pericardial pleural window creation and the wedge resection. So with the help of the robotic arm, it's very easy for you to do anything as usual. Initially, we introduced our indication for only 3 thoracic emergency, like 3 brothers. The first one is pneumothorax. In Mandarin, it's called 气胸. And the second one is Um&Cgmh. In Mandarin, it's called 脓胸. And the last one is like hemorrhage, is like 血胸. So we call it 3 brothers in emergency chest surgery. Why we choose this? Because even we could image when we advance in phase 3, we have to all we have to do the surgery is these 3 kinds. So when we compare with robotic arm and the human being's arm, you could see the operation time didn't increasing, but 100% different was the participant number. In the robotic arm, you only just 1 unit surgeon. The conversion rate was 0. It's amazing. So we advanced our technique to more typical pulmonary resection, like wedge resection, segmentomy, and lobectomy. The first one was wedge resection. As I talked previous, you could do the pneumothorax in previous, you could do the wedge resection in the later. So when we compare with 2 groups, there was no difference without any conversion rate. But when we advanced to the segmentomy, you could see one case was converted to human being screw. And this is because sometimes when you do the segmentomy, you need a more great angle. The hinge of the robotic arm might hinder your entrance road. So we log on and convert to human being screw. But for more advanced group, for like lobectomy, you could see the conversion rate is increasing. The about 1.5% will be converted to human beings group. So for our premier result, we will see it's very common. It is very easy for you to do any common emergency thoracic surgery. But for the more pulmonary malignancy resection, it depends on the incision size, the location, and the correlation of your instrument and the lymph node dissection. So it's our premier result, but I think we will improve after more advanced surgical technique or more advanced surgical instrument were introduced in thoracic surgery. The last one I will thanks to my professor to invite me to give this talk. Thank you.
Thank you, Dr. Wu, for the excellent talks. And we'll discuss the final section. And we move to the next topic by Dr. Cheng Wei-Shin is graduate from Taipei Medical University. In 2007, also the assistant professor in Department of Thoracic Surgery. And he went to Washington University, St. Louis to learn the thoracic surgery as well as the lung transplantation. And today I think he's talk on tip and tricks of the VATS and anatomical resection and possibility lymph node dissection. Dr. Chen, please. Okay, good job.
Good morning, ladies and gentlemen. And this is a great honor for me to give the presentation today. So today I'm going to talk about the tips and tricks of VATS anatomical resection and lymph node dissection. In this lecture, I will focus on my own experience of anatomical resection, and I will show several videos of my surgery. So just like Professor Liu's introduction, my name is Wei-Xin Chen. I graduated from Taipei Medical University. I finished my thoracic and cardiovascular surgery training in Lincoln Changwon Memorial Hospital. And I have been to WashU St. Louis in United States of America for lung transplantation training. Just as you know, Lincoln Changwon Memorial Hospital is the largest private medical institute in Taiwan. And Lincoln Changwon Memorial Hospital is the biggest one among the branch hospitals. So in Lincoln Changwon Memorial Hospital, we perform around 300 lobectomies and 100 segmentectomies per year. And in our hospital, we usually perform reduced pole VATS. Currently, we had around 80% biportal VATS and 20% uniportal VATS. So myself, I usually perform lobectomy by biportal method. About the sequence of the procedure, I usually dissect the fissure first. And I sometimes perform the fissureless technique if very incomplete fissure encounter. And I usually dissect the mediastinal lymph node after pulmonary resection. So I will show two videos of my surgical procedure. The first case is a patient who had right middle lobe lung cancer, and I perform biportal right middle lobe lobectomy. So just like I mentioned before, I usually use the electrocautery and combine with the stapler to divide the fissure first. So this is the fissure between right middle and right lower lobe. And then I divide the fissure with the stapler. For right middle lobectomy, I usually go from anterior to posterior. So I loop the right middle lobe PB. And I think one of the advantages of biportal VATS is that we can switch the pole freely from upper and the lower pole to facilitate the further stapling of the hyaline structure. So the second structure is the right middle lobe bronchus. And finally, I staple the right middle lobe PA from the anterior pole and remove all the adjacent lymph nodes. I will show another lobectomy. This is a patient who had left upper lobe lung cancer 2 years ago underwent a wedge resection. He had a local recurrence of left upper lobe. So we perform a biportal left upper completion lobectomy. Because of the fissure is very incomplete, so I use the fissureless technique. I dissect the left upper PV first. Just like I mentioned, I switch the camera and the stapler freely. And then I staple the PA to the apical. and then I staple the posterior branch. And I dissect the bronchus to the left upper lobe and divide it by the stapler. And then I remove all the lymph node around the hidden area. And I divide the fissure as the last step. And then I will share my experience about biportal VATS segmentectomy. I usually identify the PA, PV branches and the segmental plugs by the preoperative CT scan. Recently, the 3D image reconstruction system was introduced to our hospital. So now, for me, I will use the 3D image reconstruction for every patient if possible. And about the identification of intersegmental plane, I usually use the direct air inflation to the cut end of target bronchus. So I will also use the IVICG injection and the NIR fluorescence scope to identify the plane. And I usually divide the intersegmental plane by the stapler. So here I will show two videos of biportal VATS segmentectomy. This is a patient who had a right upper lobe early lung cancer, and we perform a S2 lobe segmentectomy. For S2 segmentectomy, I usually divide the fissure first, and then I will divide the posterior ascending artery. And then the PV to the S2. I will try to identify the recurrent A2 artery if possible. And finally, I will divide the bronchus to posterior segment. And for the patient, I use the inflation deflation method. But just like you see, the inflation deflation line is not so clear. So I just divide the fissure anatomically. And then I will remove the hidden lymph node as much as possible. And the next case is a patient who had right upper lobe stage 1 lung cancer, underwent right upper lobectomy and lymph node dissection. The patient had a secondary primary lung cancer in her right lower lung. So I performed a right S9+10 segmentectomy. So I will dissect, for S9+10 segmentectomy, I will dissect the mediastinal lymph node first. And then I will identify the PA to S9+10. And here we can see the fissure between superior segment and basal segment is quite clear. So I just divide the fissure between superior segment and basal segment. And after dividing the fissure, I try to encircle the target bronchus, being 9+10. And I staple with the stapler. And then I divide the PV to S9+10. In this case, I use the IVICG injection and use the NIR fluorescence scope to identify the intersegmental plane. In this video, you can see the intersegmental plane is quite clear by using this method. So I mark the intersegmental plane by hook electrocautery and then staple the fissure. And because time is limited, so I will mention a little about the lymph node dissection after pulmonary anatomical resection. For my principle, I usually perform radical lymph node dissection for every lobectomy patient, but for some repetitive predominant early lung cancer patient, maybe I will just do lymph node sampling. I think left side mediastinal lymph node dissection is much more difficult than right side, so I will show two videos about left side mediastinal lymph node dissection. The first case is a patient who had a left upper lobectomy, and we do a left lower paratracheal lymph node dissection. So for left lower paratracheal lymph node dissection, I will push down the PA and open a window between PA and the aorta. And I will try to avoid energy device close to the subaortic area to prevent the injury of left recurrent laryngeal nerve. So in the video, we can see the lower trachea very clear. And then I will grab up the lymphatic tissue and remove the lymph node and broccoli. And then the next video is the left subcarinary lymph node dissection by Multiport VATS. I think left side subcarinary lymph node is very difficult because the location is quite deep and influenced by the left descending aorta. So for left subcarinary lymph node dissection, I usually open the window first. I will try to dissect toward right main bronchus and divide the lymph node away from right main bronchus first. And then I will grab up the lymph node with the grasp and divide the lymph node away from the main bronchus. Because the video is quite short, maybe I will show again. So first I open the window of subcarinary area, and then I divide the lymph node away from right main bronchus. And finally, I divide the lymph node away from the main bronchus and clean all the lymph node over the subcarina area. So I will conclude my presentation here. Reduced pole pulmonary anatomical resection is quite commonly performed in our hospital, and it is a safe and feasible procedure. Radical lymph node dissection during the reduced pole VATS, I think is still challenging and require experienced surgeons and assistants. And so this is the end of my presentation. Thanks for your attention.
Thank you, Dr. Chen. I'm sorry because of the internet, the video is somewhat delayed. Dr. Saro, can we take some questions because time is quite limited? Or any questions from the side? Hello, Dr. Saro. Hello?
Hello, can you hear me?
Yeah.
Yeah. So thank you for all our 4 speakers. I think the talk has been very good and excellent. So I would like to pose a question to all the speakers because in terms of minimally invasive lung cancer surgery, I think is the norm now. It's not the new norm, but it's the norm since I think mid-2000 already. But there's always a challenge when we deal with a large tumor. I mean, I would like to ask the floor, what sort of tumor size that would you stop from doing VATS lobectomy, whether it's uniportal or biportal?
My experience, even though I do the single port surgery, encounter some breathing episode, massive breathing episode, I still use the main principle is the first one is compression, and the second one is to find out whether you could do the loop, aortic loop, but pulmonary artery loop. And if you could control breathing, you didn't need to add one more pore or open the thorax. But if you didn't have sufficient confidence to do such a maneuver, you have to, you didn't hesitate to open the thorax, is my opinion.
I would just like to add to that. Can you hear me?
Yes.
Yeah, hi. Okay, I mean, the cutoff, like what Prof. Sharul asked, it varies according to the comfort of the surgeon. But based on my experience, anything between 5 to 8 centimeters, we always have to keep at the back of our mind that either you might need to extend your incision to retract the specimen, or there's another technique that I learned over time is that once you put your specimen in the endobag, as in the endobag is brought towards the surface, you can cut the specimen or deflate the lung by allowing the air to decompress out. And by doing that, you probably can jiggle a specimen through your port. But this again depends on how solid and how big the specimen is, because if the main component is solid, then you might have trouble just taking it out through a small incision, and you probably will need to extend your incision.
Dr. Saro, I just want to, because just now the one speaker talking about the ERAS program, and have you started the ERAS program in now?
At the moment, we have not started it, but I think it's coming. I think we have not really sat down and discussed it, but I think in terms of the advantages of ERAS program, I think all hospitals should look into it, and we, myself, Dr. Siva and Prof. Jamin will look into it to implement it in our thoracic surgery program. Definitely, we will look into it. What about in Taiwan?
In Taiwan, we just try to organize this program, but I think it's quite controversial because, as you see, from my personal experience, the most advantages for the minimally invasive, I think, is not to put in the chest tube instead of the different ports or uniport or multiports. So now, actually, we have some cases that after the resection of the lung tumor and we did not put in the chest tube, the patient can just go around after surgery immediately and will discharge the other day. So I think this is quite amazing if we start to learn how to judge not to put in the chest tube after surgery. I don't know whether you got any experience in UM or not.
At the moment, we are not brave enough to not put the chest tube after surgery, after lung cancer surgery. I mean, at most we will remove it then the following day.
And Dr. Wu has some experience of the digital chest tube, chest portal. Maybe you can comment on that.
For early recovery program, we have experience of using digital drainage device. It could help you to define when is the best time to remove the chest tube. Some of my colleagues would do the tubulars. It's not chest tubulars, not whole tubulars. But for chest tubulars experience, we will find on maybe 10 to 20%. Even though you could see in the digital drainage device, there's no air leak, but you will find some non-symptomatic pneumothorax. You will find some residual space over the chest X-ray. So my suggestion is, if you want to accelerate the patient in and out, you could use the digital drainage device to accelerate the hospitalization. It's my opinion. And it's
Thank
very
you.
safe.
Yeah, we have used some experience using the digital drainage device, but in our institution, the main limiting factor for using the digital drainage device is in terms of cost. Okay? Because it costs a lot more than the traditional chest tube and chest tube bottle.
Yeah.
教授他们有个问题。
啊？
他说第二个的前那个video。
看不清楚啊，太小。
它是this
啊？ What's that？
快点。
你有什么问题？
他应该是说开入 summers。
就是网络的问题啊。
没有这个，你看他是讲。
对，我看得到。
左边。
嗯。我看到了，念一下。
你念一下。这是网络问的吗？
这个对。
刚刚问的对，他们在留言问的。
Okay.
Yeah, I see a question for me. Some surgeons believe that we might cut the ductus to improve to reach the deeper left paratracheal lymph node. But for my personal experience, I don't think cut the ductus is necessary because you can just push away the ductus and we can see the low paratracheal area very clearly. So I had a question from for Dr. Ali because of the advance of both VATS and the robotic surgery. I just wonder what is your indication for robotic lobectomy? So how you choose your patient to receive whether just VATS lobectomy or robotic lobectomy?
This is for me.
Yes.
Which man?
I mean, I only perform 5 robotic thoracic surgery when only 1 lobectomy. The only reason because I can do and perform that lobectomy actually because patient can pay the cost for robotic. I think our concern is more on cost. If you ask me, I wish I can do all of my lobectomy robotically. But of course, we have our special training which every case I do in robotic platform. My proctor from Singapore, if you know Mr. Anis, he will come and assist me and become my proctor. So since this MCO, because of this pandemic, they really limited and he can't come for travel. So I have to withhold all my robotic activities. Yeah, maybe I can comment on the after thoracic surgery without chest tube, because I think I have experience in patient which after thoracic surgery without chest tube, but only on sympathectomy, not lobectomy, because I think the lung is okay. So when before we pull the tube, we just ask the NS to expand the lung and pull off the temporary chest tube. So most of the patient can go without chest tube, and of course we repeat chest X-ray postoperatively. Yeah. Thank you.
Hi, can I ask a question to Dr. Wu in Chang'an Hospital? Can everyone hear me? Hello? I would like to ask Dr. Wu for his uni-surgeon surgery. Would that impede your training? Because I am from Singapore. I'm still under training for thoracic surgery. But if all the surgery you've been doing with you're the only surgeon, then where would your training go?
Sorry.
Can you repeat the question, please?
Sure. Because Dr. Wu was talking about uni surgeon thoracic surgery. So
Yes.
as a trainee myself, so I'm just thinking if your surgery doesn't require any assistant, so your
Yes.
trainee has no place in your OT. So would that impede the training?
Oh, you mean the Chinese training?
Yeah, so your trainee wouldn't get to scrub up in your surgery, isn't it? If you only require one surgeon, no assistant.
Okay. I will explain. Maybe it's a special case in this year of COVID-19. But when you want to train your trainee, you have the training will feel more comfortable, because for a Singapore surgeon, the most difficult part is how to cooperate with your assistant, and the assistant will keep in a posture very difficult to maintain. So sometimes you will find the scope vision is trimmer. But with the help of a robotic arm, you could tell him, okay, this is the best view from my viewpoint. So you could let him to record and to record the vision to let him practice in the later. From the simple resection, I think even the training could understand what I told, and during the process of training, you could help as an assistant, like to using a joystick to move the robotic arm and to let him know maybe the best procedure, best entrance road to let him know how to do the unisurgeon surgery.
Thank you.
Do I answer your question?
Yeah, I think so. Thanks very much.
Okay, any more questions from UM side or the participants? It's 9:15 now. Dr. Saro, you will have to continue.
Yeah, we're running a bit over time at the moment. Is there any more questions from the viewer, from the participants?
If not, then thank you so much. And actually, we look forward to our many further collaboration between our two teams. Because now, due to COVID-19 pandemic, so it's quite difficult to see each other in the operating theater. I think next year maybe we'll have chance, and we look forward to many more collaborations between UM and Chang'an Memorial Hospital here.
Yeah, sure, Prof. Lau. Yeah, I'm looking forward for this pandemic to end, because I think the main thing that this collaboration is for us to exchange surgical expertise, and the only way to do that is to visit each other theater. So unfortunately, at the moment, we can only visit each other via the internet. So hopefully, in the near future, we can physically go there and invite your team to come to our center to perform surgery as well.
Okay, we look forward to all this to make it possible, and I think we will end here. And thank you so much. Thank you, Dr. Siva. Thank you, Dr. Ali Azam. Maybe we can meet, have close contact in the future and meet in the future. Thank you.
Thank you.
Terima kasih. Okay.